Hey everyone, welcome to Cowtown Rounds. My name is Andrew Shedd, and I'm the Residency Program Director for Emergency Medicine here at Baylor All Saints Medical Center in Fort Worth, Texas. And this is our podcast. In case you didn't catch our introductory episode, we are dedicated to advancing the specialty of emergency medicine. And today we're going to kick off a series on medical education with Dr. Vivek Medapalli, who is one of our newer faculty and who recently completed a fellowship in medical education. He's going to be talking to us about how we can all be better educators when on shift in the emergency department. We encourage you to subscribe to this channel so you can be notified when we publish new content, and also please follow us on Instagram at BASEM Fort Worth. Thank you. Great to be with you all again. Like everything in emergency medicine, sometimes we always go into the emergency department. We never know what we're going to see. Mm-hmm. Yep. Today, we are going to talk about medical education because one of the things that we get asked a lot is from our faculty and senior residents, how do we teach better at the bedside? And so, Vivek, you're going to lead us out on some tools and cases today. And again, we've not looked at these before, so we're going to have to just fly by the seat of our pants. But thank you for all that you've brought to teach us today, and look forward to learning from you.
Yeah, I'm excited to talk about this stuff. So that is a loaded question every time I get asked, what do you do to teach better at bedside? Because a lot of times there's some intangibles associated with it, but there's also some teaching models that are out there. And a lot of times there's too many to count and you don't know which one to use. Yep. Sometimes that's a luxury that we don't want. So I brought 4 to us here, and I think that giving us 4 with an idea of when to use each one, as well as an example that I'm going to use with each of you. Unfortunately, I'm going to have to make you all the victim on this. It will give us a little bit of insight into how and when to use these things. So the first one that I want to focus on is something called SPIT. And when I look at a resident or a learner and I go, what's your SPIT? The looks I get are hilarious, but what it stands for is something called serious, probable, interesting, and treatable. Now, this is great for our medical students, early learners that are still working to craft a differential diagnosis. When they come to you, they give you an amazing history, an amazing physical, and then differential comes around and it's stumped. What you want to do is make sure that at any point in emergency medicine, we don't forget our serious life-threatening diagnoses, right? So always have them start with 1 to 2 serious diagnoses that they cannot miss for this case. And then I'll add in some more probable ones. What do you really think is happening with this patient if they look okay? Just for the sake of, piquing their interest and probing their brain, I'll have them think of something that's a little more interesting, a little more out of the box that may not be going on with this patient, but in a world where you've exhausted all possibilities, maybe something you consider. Now, the treatable part, some people create a separate diagnosis to say treatable and put that in a category. I like all of mine of these to be treatable because then why else are we doing this, to be quite frank. And then from here, I'll say, okay, so you have your list of diagnoses that you've now created for serious, probable, and interesting. From there, tie your work up to rule out each of these things, okay? Typically, I'll say 1 to 2 serious, 2 to 3 of probable, and 1 interesting. So, given that you will be our primary worker with the medical students and the early learners, Monique, do you mind if I use you as the example here?
I would love to.
So in these cases, I'm going to serve as the faculty, and I'll have you all serve as the learner, just to get the idea of the back and forth that might go along with this. Okay. So, what do you have for me, Monique? I hear you have a case that's ready to go. You've got a patient that you've seen.
Yeah, I just went and saw this patient. She's a 21-year-old female, no significant past medical history, is coming with acute onset of lower abdominal pain as well as vaginal bleeding starting today.
Okay, so I agree. Let's craft your differential here. So to help guide your workup, give me 1 or 2 things that are most serious that could be life-threatening here. Give me a couple of more that are probable what she's likely going through, and then give me 1 just in case it's interesting that may be happening but is a little less likely.
Okay, so for serious things that we don't want to miss, I would consider a ruptured ectopic pregnancy as well as ovarian torsion.
Yeah, those are our two very big ones, right? You cannot miss those things in our early, or, in our younger patients with lower abdominal pain. That's why we get our pregnancy test, right, on all these people. Do you really think she's having one of those things, or does she look okay?
She looks okay. I think it's less likely, but definitely want to consider it, and we'd want to follow up on our labs and our pregnancy test as well.
Fair enough. Now, what do you actually think's going on then?
I think it could be. Depending on the pregnancy test, it could be an early intrauterine pregnancy with a threatened miscarriage. If she's not pregnant, it could be a ovarian cyst, a ruptured cyst that could be going on as well.
Yeah, likely things being likely. I like where your head's at. Now, let's think it outside of the box. If you were to say that something kind of crazy out of here, what things aside from those things could this be?
Yeah, I mean, she's young, but that doesn't mean that we don't consider things like tumors, malignancy. An ovarian tumor would be something that could be interesting in this case.
Absolutely. And then you have, lower abdominal pain, kind of thinking that pelvic region. What are some other things that are treatable around there?
Definitely PID, pelvic inflammatory disease. We got to think about that.
Yeah, you don't want to miss that. You don't want to compromise future fertility, that kind of stuff. So I think that's a great start. I think you've thought through a very comprehensive, robust differential. Now, you're thinking about the important things like a ruptured ectopic or ovarian torsion that you have to rule out and make sure that they're not having before you discharge them or consider discharging them. So what does she look like, and how do you kind of want to proceed from here?
So at this point now, after my evaluation, her blood pressures are getting a little bit soft.
Okay.
She is pretty tender on her exam, and then I looked up the labs that we got and the results, and she does have a positive pregnancy test.
Okay, well, good job ordering that up front. Nice work. So where do you want to go from here?
So I definitely, I'm going to grab the ultrasound and just do a bedside fast exam just to look for any bleeding. And then I want to make sure to follow up, a CBC, a BMP, an HCG, and we should definitely get a type and screen if we're worried about bleeding.
Okay, good deal. If she doesn't have an ectopic or we get that official ultrasound back, where do you want to go from here?
In that case, if everything from that end looked okay, we should probably get a pelvic ultrasound, and then we should probably do a pelvic exam as well. Fair
enough. You want to look for cervical motion tenderness, look for any purulence, any other things that you can really imagine.
Yes.
Excellent. So great job crafting a differential. So that's kind of how spit goes. It's kind of end scene. We're out of that.
Very good job.
Yes, excellent work.
Thank you.
But that's a great way to probe your early learners to try and get a more robust differential. Yeah. A lot of times I'll say, hey, use spit to craft this in your MDM because it shows a very robust thought process for your MDM as well. Yeah. I've done this with several of our interns. I've done this with our medical students and sub-Is that come through. And they seem to love having a mnemonic that they can reference every time they craft a differential. And oftentimes I'll say, hey, use it this time. The next time you go see a patient, try to do the same thing. Yeah. And a different patient with different chief complaints will create this huge medical knowledge bank that they're looking for. I've gotten great feedback on that one. Yeah. I use that almost every shift.
Yeah, no, I love this model. I think we forget what medical students go through in their training, and if you reflect back to the very far days of medical school, most of their education is focused around multiple choice questions and single best answers. So they're trained to look for what is the one single answer. And what I like to tell my medical students is, as an EM physician, I don't have to be right. I can't be wrong.
That's so clear. That's so key.
So we can't miss the important things. So this is a really easy framework for students to practice stretching that differential muscle and let me think just thinking different categories. Vindicates is a really common model for differentials, but it's so unwieldy in the ED. Spit's really easy. It kind of focuses on the three things, the 3 to 4 things that we're looking for. So I think it's a great thing to help with, just like you said, our medical students and early residents. It really just helps them build that muscle up.
Good.
So and the other thing I like about this is you can use this to help guide your learners in obtaining information.
Yeah.
When you're doing your history and physical, coaching them to think about this model themselves, so they're asking questions around the serious things, the probable, etc. One question I have, so medicine is full of acronyms and mnemonics. How do you remember the acronyms for education and when to use them, or do you just build it into your muscle memory?
I try to build it into my muscle memory as much as possible, and because there are so many, I like to figure out 3 or 4 things that actually do work for me. and are things that I will carry with me through each shift. So I try not to keep this entire laundry list of mnemonics in my head. I say, hey, here are 4 models that I've got. I'm going to try and focus on that. I don't like creating mnemonics for mnemonics. That's kind of where I don't want to go with these things. But I like it when there's 3 to 4 letter long things that you can use, and only a few of those that you carry for each shift. So that's why I picked 4 here that are going to be, I think the most useful.
Yeah.
Absolutely.
Any other thoughts on SPIT before we move on to the next one?
Let's synopsize this.
Yeah.
So going back to the question that we're trying to answer is, a senior resident or a faculty member comes to you and says, how do I teach better at the bedside? We are saying consider using the SPIT model, serious, probable, interesting, treatable, when helping a learner think through their differential diagnosis and how they're going to place their initial orders.
Exactly.
Remember to SPIT.
That's right.
Remember to spit.
All right. My next one to teach you all is something called SNAPS, okay? Now, SNAPS on the other end of the spectrum is great for your late, more senior resident. It's great for a late intern as well as they're transitioning into that role. It is admittedly a very learner-guided approach, meaning they will come to you and do the majority of these steps naturally, and you have to keep in your head what things they've already achieved and what step in their management or what step in their reasoning they need help with. That's when they will often naturally come to you with that first P, that probe step, and say, I need help with this. And that's where you jump in as the faculty, the expert, to help out. So it's a learner-guided approach to guide discussion and note any gaps in knowledge and fill in little gaps in people that have already established some of it. So what SNAP stands for is summarize, narrow, analyze, probe, plan. And that last S is select a learning plan or select the next steps. So it's great for encouraging autonomy. It might not be the best thing for the early learner that is just so confused that they're working through how to work through things.
Sure.
Yeah.
So Chinmay, I'm going to have you work with me on this
happy
one. Since this is so learner-driven, I'm going to have you kind of go through the majority of things, and then I will say, hey, you did a great job summarizing, or you did a great job through each of these different steps. And really, the faculty here really only has to say a little bit. It's an easy thing to do. It's nice. It's great for the faculty. So let's go ahead and get started. So Chinmay, you've got a patient for me to see, right?
I've got a tricky one here. So I've got this patient here, 45-year-old male, sudden onset dyspnea, started about an hour ago. He's 94% on room air. His vitals look otherwise okay, though. His lungs are clear. He's breathing pretty hard, though. He's really working in there.
Okay.
He had surgery recently, too, but has it was his knee. They have it wrapped up, so I haven't had a chance to look at it yet.
Fair enough. That was a great summary step. So we went through that first S, that's summarize.
So his presentation's pretty vague, but I've narrowed it down to ACS, PE, pneumonia, or a pneumothorax.
Good. Great narrowing of the differential. So that's the N, the narrow step.
Okay. I'll be honest, I'm pretty concerned for a PE based on how acute his presentation is, given the context of his surgery. He doesn't have any chest pain or fever.
Okay. So that serves as the A, or the analyze. The resident or the learner in this case has done some analysis on what their differential is and what's most likely here.
Yeah. I haven't had a lot of patients with an acute PE before, but do you think we should get a CT scan to confirm this, or should I go ahead and just start him on heparin right away because I think it's most likely? And if it is a PE, how will I know if I can discharge him?
And bam, right there. The three of you, other than me at this table, how many of you experienced this, where you've had a learner come up to you and they present this case beautifully to you, and then you get to the point where they say, what would you do? Because I don't know what to do.
Yep.
Happens all the time. Happens in the majority of cases, I'd say. And that's where you jump in as the expert to say, okay, now let's start our learning process and think. So now this is the probe step, the P. And then this is where I come in as the educator or the faculty member. And I say, great summary, great differential, good initial plan. I like what you're thinking. Now, when we come to patients, and to answer your question, when we come to patients like this that we're thinking about scan or heparin or thrombolytics right away, we want to assess the stability of the patient. If they are stable hemodynamically, then we can probably afford to go to the CT scan and confirm our diagnosis first, right? If they're a little more tenuous, or we have to act quickly. There are other models we can use. Sometimes we can get an ultrasound, like Drew, like you mentioned earlier. An ultrasound can show us quite a bit of information for a PE. If they're hypotensive and about to crash on us, then that's a totally different story. We may have to act right away and give thrombolytics. Depending on what your patient looks like, we can go from there. Now you've come up with a plan together, as you as the faculty and as the resident. And that allows you to join them where they are, so you're not lecturing them and belaboring the point of what they already know, and it allows you to reach a more senior resident where they need to be met.
Yeah.
Okay? So let's continue forward.
Oh, sounds like a plan, Dr. Mattapalli. I'll look up the PESI score and the classifications for different types of PE based on stability.
Exactly. So now we've selected our learning issue. They're going to go ahead and look at the classification of the PE and when to do these certain things based on what you just taught them. So see, that's a little bit different than SPIT.
Yeah.
Just a slightly different kind of model where you're now not focusing on the differential itself. You're focusing on plans and next step and reasoning. Okay?
Yeah.
So again, just to summarize, narrow, analyze, probe, plan, and select your learning issue.
Yeah.
Excellent.
Yeah.
Any thoughts?
I like this one. I think that it also helps the learner comes to the conclusion of where their deficit is as well in the patient plan and workup, because they, you probe and you help get them there, but then they identify, okay, I need to, this is where I'm weak, I need to go look this up or look into this. So again, it feeds into that motivational learner to be a part of this, but I really like that.
Yeah. Good.
Yeah, I like this too. And one thing I like to do, particularly with senior residents, is probe things to figure out what they're going to do after they graduate, or see if they know, what would they do if if you were at a rural ED, if you were at a freestanding ED, if the patient had a severe contrast allergy, if they were already on, Lovenox or such. And so try to ask those kind of second, third order questions to figure out, because sometimes they may not have thought about those things. So I really like the probe section on here. Is that kind of what you think about when you think about probe? Is you think about questions?
It can be both ways. I think with the model itself, they have it as the learner probing you for help and feedback on their efforts, but it promotes further discussion, like you mentioned, where you as the educator can now probe them further on what they would do in hypothetical scenarios, and that is a very valuable thing because it creates new branch points from a single topic. I think it works great.
What I like about this is, especially the first half of this, the summarize, narrow, analyze. It's kind of how we think as attending physicians on patient care. We kind of have a summary. You can go through there. It almost strikes me that if a resident truly feels lost, even before that you could use that. Narrow your differential for me. Help them walk through this thought process. Now that you have your differential, what do you think about the likelihood, getting that back and forth, more that Socratic method, but using these as to help your learner who's lost along that patient care, get them back on track with these steps.
Exactly. It works really well, and I've tried it in practice. It works well. It does require a motivated learner that comes to you and says, "Hey, I've gotten this far. Can you help me with this point?" If it doesn't help as much when they're totally lost. To be quite honest.
Yeah.
If you could, tell me a little bit about how you, let's say you have a motivated learner who's not familiar with this flow.
Yeah.
How do you help them use this?
A lot of times I'll guide them through the process if they're not familiar or they're not organized in the way that this model kind of presents. I'll say, tell me a summary of your case. Okay. And they'll summarize the case, and I'll say, okay, what do you think your differential is? Can you narrow it to 4 or 5 things? They'll narrow their differential. I'll say, well, based on that, what do you think is most likely? Now, they've done the analyze. And then I'll say, okay, so where are you stuck? So what do you think we should do with this patient? That's getting their probe to make them think. And then I'll give them a plan together. That's typically how I approach it. Yeah. If they don't come up to me with a presentation that fits this bill, which is very common, let's be honest. So that is SNAPS.
All right, somebody synopsize this for our audience.
Yeah.
SNAPS is, and when do we use it?
Yeah. So I'll take a crack at it. So SNAPS is a learner-centric framework for, your more advanced learner. You're looking at kind of your second year, third year resident, if you're talking about an emergency medicine residency program. It allows them to kind of really guide the discussion and kind of find those gaps in their own knowledge. The acronym is summarize, narrow, analyze, probe, and plan. They would summarize the patient, they would narrow their differential, they'd analyze their differential and treatment plans. At that point, the faculty, either the learner themselves would probe with what they're unsure of, or the faculty would help them identify the question that's central to the patient's care spot. You'd come up with the plan, and then you'd come up with a kind of a select learning issue.
Exactly.
This is great. I feel like I'm learning a lot.
Yeah.
Very good. I'm glad. So the next thing I want to move on is the 1 minute preceptor. Now, the 1 minute preceptor is the one that's truly actually validated and evidence-based within emergency medicine. This has had a lot of research done on it. I believe back in the 80s or so, they really did some studies to see how it does and how learners gain knowledge from this. They found that it works well, and they even wrote that it promotes higher order thinking, whatever that entails. So it does have a lot of practice to it already. This is good for all stages. It's a nice versatile tool because it gives you about 1 to 2 minutes where you can sit down and actually have a full discussion with your learner and kind of probe them back and forth and have this actual discussion with them. It's good for case-based micro-teaching, so they'll come to you with a case, of course, and you'll follow these core steps. Now, the steps here are a little bit, it's not necessarily a mnemonic, it's a little bit more of a flow. So this is first, get a commitment. So they'll present you a case, and that's essentially getting the commitment. It's not much more than that. Then you'll probe for their reasoning, and that's kind of more faculty-driven. You'll have to reach in and kind of figure out where they're thinking. The important thing with this method is that you, as the expert, are going to be teaching them some sort of general rule. And they take that rule as their clinical pearl and move with it. So now step 3 is teach a general rule. Then step 4 and 5 are a little bit more feedback in here. You go with reinforcing positives and correcting errors and whatever method you like to use for feedback. But one thing that's important here is to try and reinforce this pearl as much as possible through shift. Try not to make it just a 1 minute thing, try to make it a spaced repetition thing where they hear about this multiple times and they can commit it to memory.
Sure.
Okay? Drew, unfortunately I have to pick on you for this one.
Let's do it.
So let's talk through a patient case. So I've heard you've got a patient for me as well.
That's correct. I have a patient here. I think he's ready to go. He's a 74-year-old guy. He passed out earlier today while he was mowing the lawn. He looked a little dry and was a bit tachycardic, so I gave him some fluids, and he's feeling better now. His heart rate is about 101.
Okay, I like the start. So what do you really think caused him to pass out?
I think he's probably just hypovolemic. I don't think it's anything like cardiac. He's saturating well. He has no chest pain.
Okay. So did you do any workup to rule out any cardiac causes on him?
His EKG showed normal sinus rhythm without any heart block or ischemic changes, and his exam showed clear lungs and no edema, and he felt better after fluids.
Okay. I mean, I like your reasoning. I think it's definitely a good possibility that it's due to just hypovolemia. But older people get tricky, and a lot of times dizziness and syncope with elderly patients can have some overlapping causes, some of which are a little more dangerous and a little scary. General rule for me personally is that I don't let people that are above 60 that pass out leave my ED without some EKG and troponins. I like to make sure 100% that cardiac ischemia is not at play here. I saw we got the EKG, but I saw we didn't do any troponins. You did a good job recognizing he was dry and needed fluids. You probably made him feel a lot better, which is great. But just next time, make sure to document an EKG and see if the troponins are good, just to be extra safe and make sure we're covering all of our bases here. That's essentially how the 1 minute preceptor goes. You get the case, you see where you can possibly add in some pearls here. You give them a rule. In this case, it was the above 60, go ahead and get an EKG and troponins and syncope. And then you give them feedback from there. So in this case, you got a commitment. You ask, what do you really think is causing this patient's dizziness? Because you're now committing them to think and present their reasoning, essentially. Yeah. And it makes them take a stand and defend their thought process. Now, you also probe for some supporting evidence. You say, what are those cardiac causes that you ruled out, and how did you do so? That made them think about their workup so far and encourage some learning. Then you teach a rule, as we touched before, and then you reinforce what was done well. So in this case, I said, you did a good job giving fluids and making the patient feel better. It builds confidence. So I think we all know it's not best to just dogpile someone, give bad feedback to try and correct them. You want to try and give some good, some bad in a mix to encourage confidence and make sure that they're taking your feedback with actual without a grain of salt, really. And then you correct your errors. Just document an EKG and troponins next time, and allow for some constructive feedback that they can take. The next time they get a syncope patient later on, they can come up to you and say, hey, I've got another elderly patient with syncope. I've done an EKG and troponins this time. Looks great. Now they're really ready to go.
Yeah, they're ready.
I promise you, they're ready to go. This one is more traditional teaching. I think we've all done this. Any thoughts?
Yeah, I really love this framework. The few things that stick out to me, kind of at a global scale, like really talking through all of these, I think we all kind of have our toolbox as clinical physicians, right? When I go in to talk to a patient about taking antibiotics, if I talk to them about a negative heart troponin, we kind of had that spiel that we've kind of built in our head on how we address those situations. And it took me a while to realize I kind of need to start building that toolbox for education as well. And so these are great tools to approach different things. So 1 minute preceptor for me is almost how I always approach PE workups with medical students, because they'll have PE on their differential. And then I'll say, what do you want to do? And like, well, I guess we could get a troponin or a dimer, or we could get a dimer or a CT scan, or we could do a Wells or a Perkin. I'm like, okay, but what do you want to do? And I for me, the most important part of this to really get into it is to get that commitment. And what I tell learners is like, in general, if you pick something, like it's as a medical student especially, like it's the best time to be in medicine. You can be wrong as much as you want. It's not going to harm the patient. Take full advantage of that. Really committing to something and then seeing where your thought process broke down is so much more insightful than hearing an attending give you their PE lecture, because if you haven't committed to something, it just kind of washes over you. It makes sense when it's explained, but you don't see where you weren't able to connect the dots. So,
plus the residents just thinking about the next patient they need to see. It's hard to kind of listen to a micro lecture.
Oh yeah.
But one thing I wanted to ask y'all, because there's different approaches to this. If you have a resident or another learner present a case, and there's multiple layers of issues that you either want to correct or teach on, how do you isolate it to the top one or two so that you don't overwhelm them?
That's a great question. I think it's what's most pressing in that exact moment. So if there is a critical error that you're trying to fix, like something that could genuinely harm a patient, of course that one's going to come first.
Yeah.
Now, sometimes I'll split those. If I see it as a recurring theme, sometimes I'll split those among different patient cases. I'll say for this one, for example, it could be focusing on this type of reasoning. For another one, it could be the next type. And then that allows them to associate that teaching point with the patient. So they're not overwhelmed at once with, hey, you messed up really bad. What they're hearing then is you messed up really badly on this patient, which is the exact opposite of what you want to do, right? So I like to split it as much as possible and have them take 3 to 5 learning points home with them.
Yeah, at the end of the shift. I agree. I think splitting it up and also having that balance, which is what was done in this case with the 1 minute preceptor, of still highlighting the things that they did well, especially for the early learners when it's difficult to commit, because again, you don't want to be wrong, you want to impress your attending, so you don't want to make them feel bad about committing, because that's what to a decision, that's what we want. But I think having that balance of, okay, we can learn from this, we can all learn from this, let's talk about it, but let's also remember all these things that you did well with this case, and remember to carry that as well to your next case.
Absolutely. Yeah. And to your question, if a learner has multiple issues, depending on the severity and the type of issue, I'll split it between 2 patients. Like with a more pressing acute medical care might go to the patient that we're seeing now. But then for, let's say they struggled with their presentation, I might say, hey, next time I want you to make sure you give me your differential on your next patient encounter. So that way I can kind of they are focused on that issue for that next encounter, I can address it the next time around.
The other thing I will do sometimes, if time does permit and they're not jumping to see another patient right away, this is a great time to pose a hypothetical and give them a hypothetical other patient where you intentionally are being a little mean and you're leading them to make that error. And you know they're going to make that error. And that's when you say, okay, now let's jump in and correct that one. And it dovetails off of the one that you just did. But that's, of course, time dependent.
Sure.
Yeah, and sometimes, especially on a really busy shift, I like to just say, hey, I need you to order these 5 or 6 things. The EKG is important because we need to make sure they don't have an AV block or et cetera. And I want to debrief more on this case at the end of the shift. And then maybe I'll make a little note to talk about it with them later on.
Yeah. So now, going off of that, how many of you have had a patient where where either the learner or someone has seen this patient earlier in the day, they were discharged, and they come back to you either critical or a little bit worse?
The
Yes.
dreaded, do you remember that patient?
Yes.
Nobody
Oh,
likes
no.
We've all had that.
The
Oh,
worst
no.
sentences in emergency medicine.
Nobody likes hearing that phrase, and there is a way to try and phrase that to make them learn from it and not feel bad about it, and that's what I want to get to right now. So it's something called frames. This is great for your late intern, senior resident, kind of those later learners that have a robust thought process already. This is very educator driven. This is you telling them feedback on a case and how they can improve on it. So this stands for it's frames. So it stands for feedback, rule, alternatives, mistake, and explanation. So it's another feedback model that provides a rule. So it tells you, hey, in these kinds of patients, this is what I do, and this is what I do to not miss what happened here. It's really good for reflection. And then it also corrects cognitive biases if those do present. It's really good for bounce back patients because you don't want to tell someone, hey, your patient bounced back.
Yeah.
You don't like saying that.
That's why you lead with the patient's fine, but
Yes.
Yeah, patient's okay. Everything's okay, but just want to update you and tell you where we can all improve.
Yeah.
So Chimmy, I'm going to have you work with me on
Yeah,
this one.
absolutely.
I'm going to just present kind of the scenario that we're working with,
Sure.
and then we'll kind of just jump right into it. So the scenario that we have is a 56-year-old woman, history of diabetes, that came in with some upper abdominal pain. Every third patient we have, it sounds like. They were discharged with GERD, and then presented later in the day hypotensive with a STEMI. It can happen, right?
Can happen.
So this is where the educator starts the conversation. So in this case, I would lead by saying, hey, I just noticed you saw this patient a little bit earlier in discharge, sure. What'd she look like then? And what was your thought process when she came that time?
Oh my goodness, wait, is that her? Like a few hours ago, she was just fine, had some like upper abdominal pain, has a past medical history of diabetes. We gave her some antacids. Her electrolytes looked good, so I didn't think she had DKA. Her CBC looked okay. She was feeling better, so I sent her home with some famotidine.
Yeah, I mean, it's okay. I mean, this happens all the time. I mean, she's doing okay. We're seeing her again, and again, I'm glad she came back. That's what return precautions are for.
Yeah.
But the thing is, there's a lot of patients sometimes that can sneak up on you, especially these. So people that come in with vague abdominal pain, you kind of have to think outside of the box sometimes. If I have me personally, if I have a diabetic female, or one of the two really, like an older female or a diabetic with upper abdominal pain, I start to get worried about cardiac ischemia, even if it really does seem like clear-cut GERD. Just because diabetes is a risk factor on its own, sometimes these patients really sneak up on you, and that inferior wall of the heart just sits right abutting the upper abdomen.
Yeah.
So a lot of times they'll just sneak up on you. Because what else could this be, right?
Yeah, I guess an atypical MI.
Yeah, and these are scary. So mistake wasn't falling into it. It's just it was probably just anchoring on GERD a little bit early, and that happens. We call this premature closure. It's just a bias that all of us fall into, even after years of practice. So the key is just recognizing the red flags next time and just trying to see if you can catch it up front. So that's how this goes. As you can see, it's a lot of me talking. It's a lot of faculty-driven education here. In this case, just to go through the individual steps, feedback, we're asking in a non-judgmental way what the thought process was. I mentioned it by saying, hey, you saw her a little bit earlier. What'd she look like then, and what'd you think was going on? It's not necessarily, hey, what were you thinking? How could this happen?
Right.
It's less of that, more of, hey, this is what happened earlier. What happened then versus what happened now.
So more like soliciting feedback, not giving. Okay,
Soliciting feedback and having them meet you halfway.
Yeah.
Then you hear what their presentation is. You give the rule that you typically have. For me, it's sure in these particular patients, I'll get an EKG and tropes up front, even if they don't present with anginal chest pain.
Yeah.
So in the alternative step, so the faculty has to ask, what are some alternative diagnoses that could fit the picture? And typically it's the one they're presenting with. That's what it comes down to. And then you explain the mistake. So that's the mistake step, the M. And the mistake was going to be anchoring on that previous diagnosis of GERD. And then you explain future learning by learning from this opportunity, saying, hey, this time or next time, try not to focus on the GERD and the antacids helping. Try to broaden out a little bit and make sure you're not forgetting scary things. Goes back to spit too.
Yeah.
Of course.
That's what I was just going to
All
say.
goes back together.
Yep.
So don't forget your scary diagnoses is what this always comes down to, huh? So thoughts on feedback mechanisms with this one?
Yeah, no, I love this. The thing that, for me, that I've taken away from this scenario, that I think is always important to remember is timing of using this. We actually had, in previous years, we had a very impactful M&M that a resident presented and talked not only about the case, but when they were told about the case. They were told at the beginning of the shift, and they kind of like shut down. They couldn't focus, and the faculty member actually had come to me later. Like, I told this resident, and they seemed like nonplussed about it. Like, they didn't seem like they were affected, but like it just, the resident kind of just quieted and shut down. So I think this is a great framework, just being mindful of when and where to have this, especially depending on the severity. Like, again, let's say it was a missed AKI or something, maybe a little less serious versus like, a missed pediatric illness that caused like a death or something. Like, always judge the severity, but I think when to initiate this process, I think is an important thing to talk about too. Like, just being mindful, like jumping a learner at the beginning of a shift with a serious miss is not setting them up to succeed on that shift and not being ready for that feedback. So
That's good.
Yeah, I like this one. I try to tell learners too, and if something like this comes up, I mean, we've all made mistakes. We've all forgotten things. We've all forgotten to order one test or another for whatever reason. And honestly, those are some of the cases that stick with me and I never forget. And I tend to, not make that mistake again because I made it once and it didn't go the way I'd hoped it would. And so I try to remind them of that. We all do this, but next time you're going to think back to this case and you're not going to forget, or it's going to come to your mind to get the EKG, get the troponins, because this did happen. So just to kind of emphasize that with the learner.
Yeah, discharging patients is one of the most dangerous things we do. I'm sure we've all heard that from
yeah.
faculty in the past. And so just giving them the opportunity to think through what is your kind of discharge checklist. Re-looking at your results, your vital signs, what studies you ordered, rethinking through your differential is always a good practice. And this is such a great opportunity to just provide not only coaching on the case, but what are the things you can do to try to be more systematic in the future.
Absolutely.
Yeah.
And I love the conversation about like the mistake and the fact that this vignette specifically mentioned like biases. I'm not sure, are any of y'all familiar with cross-carry cognitive decisions to respond, CDRs? Fascinating article, highly recommend you look into it. So cross-carry pretty much creates a list of these CDRs, cognitive dispositions to respond, or biases, and it goes over the different way we make mistakes, and then like what led to that. So like anchoring, omission, commission, it's like a list of like 20. Usually when I have a resident present an M&M case, I actually give them that article and have them go through the list and see like where they think these things came from. But if you're getting prepared to talk to a resident about this, it sometimes is helpful because it provides this isn't a you made a bad decision thing. It's like, hey, these are inherent mistakes that we make in thinking, and so like here's the mistake, just like that we discussed here, like the I'm trying to remember which one we use. Do we use premature closure? Is that right?
Yeah, for sure.
And then like and how to approach that, because again, like you said, we all make mistakes. Yeah. The goal is to learn from them.
Yeah, and I mean, I do want to point out that this one did have a very clear like name to the bias that you had.
Yeah.
You don't have to necessarily mention that to the learner. You can say, hey, this is what happened, and we just want to focus on not doing that next time. You don't have to give a name to it a lot of times. This model will try to make you do it, but that if you don't have one, you don't have to.
For sure.
Excellent. Well, somebody synopsize frames for us, for faculty or others who might be listening, and then maybe Vivek, you can provide us a summary of all four. Who wants to take on that?
I can take frames.
All right, excellent.
Okay, so frames is a learning education tool best best designed to help kind of the late intern, senior resident. It is very teacher driven. It focuses on improving the process of reasoning. And it's especially great after making some kind of diagnostic mistake, a miss. And unfortunately, it stands for feedback, rule, alternatives, mistake, and explanation. It really builds a lot of time for reflection with the learner. A couple of things we mentioned here. I think making sure you're in the right setting, because these can be some heavy topics, and you want to make sure that there's the appropriate time and the appropriate place to have these conversations. But it really gives your learner some time to reflect.
Yeah,
That's
very
wonderful.
Excellent.
Yeah.
Before we finish, I'd love to get your thoughts on this, Vivek. So for a lot of faculty, like we get, like Drew and I hear a lot from our clinical faculty that they're really interested in more bedside teaching skills, but a lot of these things can sometimes feel a little inapproachable. Like they're just hard to like integrate into their actual practice. Like they can read the words and it makes sense. Like what would you recommend to someone, thank goodness for clinical faculty. They see so many patients, they do so much clinical time. How would you encourage somebody like that to take one of these and like build into their practice?
A lot of times I'll kind of just ease them into one and go one by one. I won't
Yeah.
present them with all of these at once and say, here, good luck. Figure out which learner you got, and then go from there. They're gonna be like, dude, I have so many patients to see. This is not it. I'll usually start them with spit and say, hey, you can typically use it with any learner.
Yeah.
And I'll say, hey, try this one, and if you like how this one runs, I can give you another one.
Yeah.
And another one. I'll say, here, once we get to 4, we're good. I think we've built your bank of bedside teaching models that will get you to 99% of where you need to be.
Sure.
And once they see that one is relatively easy to use, they can start using the other ones pretty easily too.
Yeah, that makes sense. I think for me, I've recently been working on a new kind of like framework for how I start and end my shifts. Yeah. And it's the first time in a little bit I've like put a lot of intentional effort into like changing my teaching practice. And so for me, I think exactly what you're saying, like I think sometimes having one of these that you're taking into the shift today, like I am going to use the spit model today, because I think a lot of times if you're waiting to like find the right opportunity and you haven't planned to use it that day, it can be hard to fit it in. But I'll even tell my learner, like, hey, today I'm going to try something new. This is like, what is your shift goals? Here's my shift goal. I'm going to try to use this thing today. And kind of helps like set that tone and kind of gets me ready for that. And then you could print it out and just have it available there. I think that could be one way that people who are like trying to build these tools up could use it.
That's a great point. And I think the other thing is to try to assess what the issue is that the faculty member is dealing with, because sometimes I struggle when there are a list of issues and how to address them all or how to pick.
Sure.
Sometimes it's how to give feedback at the end of the shift. And so trying to figure out what is the issue and then see if you can direct it or tailor it for it.
Definitely.
Absolutely.
Well, I do want to take a few minutes just to summarize what we learned today, which
do.
is quite a bit. So I do want to start with SPIT. That's the first one we did with Monique here. It stands for Serious, Probable, Interesting, and Treatable. This is a great differential diagnosis crafting tool built primarily for early learners that lets you craft a differential and help them when they're stumped, really. Lets them not forget life-threatening diagnoses that could harm the patient. So this is always a great one to start out with. If you are to pick one model to start with, this is my recommendation for doing it. This is what I started with. This is what I recommend early educators to start with, and even my senior residents when they're working with sub-Is themselves on shift to try and do themselves. And it's gotten good feedback on just my anecdotal end. Next, we talked about SNAPs. This is great for our late interns, early senior residents, someone that's more self-guided, learner-dependent resource that allows them to guide the discussion, and then they will meet you at the point where they have the gap in their knowledge. It's great for that. So this stands for Summarize, Narrow, Analyze, Probe, Plan, and Select a Learning Plan. It's great for encouraging autonomy. It creates their reasoning process themselves. So again, great for those later learners. The 1-minute preceptor we talked about is good for all stages. It's evidence-based. It's good for case-based micro-teaching. This is getting a commitment, probing for reasoning, teaching that rule, reinforcing positives, and correcting any errors. So again, this is a rule-based thing where you provide a teaching pearl that they can carry with them to this shift and future shifts. Lastly, we focus on frames. which is focused primarily on correcting a previous mistake and providing feedback. So this is good for those later learners as well. It's primarily faculty and educator driven, where you are giving the feedback in a way that's receptive for the learner. This stands for feedback, rule, alternatives, mistake, and explanation. And this is great for reflection, prevents cognitive bias, good for bounce backs. So, thank you all for joining me on this one.
Thank
Hope
you.
learned something.
Great.
Thank you. This
This
is
has been
fantastic.
Yeah. And now when we have a faculty member or senior resident ask, how can they be a better bedside teacher, we can say, watch episode 2,
Yeah.
Cowtown Rounds with Vivek Medapali.
Oh, yeah.
Love it.
Love it.
If you've not hit the subscribe button, please do it now. We're going to try to put out an episode like this every week or so with maybe some other shorter content sprinkled in. And thank y'all for being here. This is fantastic.
Absolutely.
Thanks
Thank
for having
you.
us.
for having us.
All
Thanks.
right. Y'all have a great day.
You
You too.
too.